Hello, everyone. My name is Marti Arvin. I'm an executive advisor for CynergisTek. We are a healthcare consultancy that does privacy, information security, and general compliance consulting work. A little bit about myself. As you can see on the screen, am an attorney by training. I've been with this company for about 4.5 years, but prior to that, I spent about 18 years, a little over 18 years in-house as a chief compliance and privacy officer. So done a lot of work in the compliance realm, worked with the HIPAA regulations, both the privacy, security, and the breach notification regulations. And so this ties in a bit to that, but really today what we're going to talk about are two different rules that just got promulgated. The information blocking rule promulgated by the Office for the National Coordinator and the interoperability rule promulgated by CMS. And I want to be clear at the beginning and make sure everybody understands these are pretty big rules and there's a lot in them, but I'm not going to be talking about some of the components of it. I'm really going to be focusing in on some factors and issues that are important things for providers to know. So if you are a healthcare certified IT developer, this is not going to really be a presentation that addresses what you need to do under the rule. This is going to be more of a presentation on what healthcare providers like hospitals, physician practices, and others need to do. And so I'm going to do a brief overview of both rules, of the information blocking rule and of the interoperability rule. And I'm going to talk about what I think are some of the key activities you should be engaging in already and considering and thinking about. And just a couple of key activities that I think you're going to need to think about, but you have a little more breathing room around them. And then at the end of the recording, we will have about a 15-minute live Q&A session. So as you're listening to this recording, please be thinking about any questions you might have. And I'll be happy to answer those in the live Q&A after you've listened to the recording. So let's dive right in. So let's first start with an overview of the information blocking rule. Under the rule, it talks about 4 types of actors. And so when I use the term actor, that is a defined term in the information blocking rule. And it defines the 4 separate types of actors. The first one being the health IT developer of certified health IT. And it's a little bit difficult to see my full screen in recording this, so I apologize if I move around just a bit to make sure I cover this correctly. It's an individual or entity other than a healthcare provider that self-develops health IT for its own use. So if you've developed something internally and that's what you're using for some purpose, that doesn't fit within this definition. But it does talk about the developer that either develops or offers health IT, and which has, at the time that engages in a practice that could be subject to the information blocking claim, has 1 or more health IT modules certified under the program by the Office of the National Coordinator. So you need to think through whether you offer that. And I'll talk more about that in a moment and why that's going to be important for healthcare providers to understand. Then, of course, they have a definition for healthcare provider. I didn't include the whole thing here. It's a pretty standard definition that you might expect for what is a healthcare provider. So if you're a hospital, physician practice, skilled nursing facility, those types of entities, then you're going to fit the definition of a provider actor under the information blocking rule. It also defines health information exchanges and health information networks. So that's what I'm referring to here by HIEs or HINs. Now, for purposes of this rule, the two are defined exactly the same. And it's an individual or entity that determines, controls, or has discretion to administer any requirement, policy, or agreement that permits, enables, or requires the use of any technology or service to access, exchange, or use electronic health information. And we'll talk about electronic health information in the moment. It's not quite the same as PHI under HIPAA, and it is a new definition under the regulations. but it's among more than 2 unaffiliated individuals or entities. So you have to think through and consider, are they affiliated entities? And is there more than 2 of them? There have to be at least 3 to fit under these definitions. And it's a matter that enables them to exchange with each other, and it's for treatment, payment, or operation purposes. So if there's some other sort of exchange you've got set up, maybe perhaps you've got something set up for research, assuming you fit all the author obligations to do that exchange, that wouldn't be part of this definition because you haven't set it up for treatment, payment, or operations. But anything you have set up for TPO that fits the rest of the definition is going to pull you under the HIE or HIN definition. Other definitions, of course, what is information blocking? A practice that, except if it's required by law or it's covered by one of the exceptions of the rule, is likely to interfere with the access, exchange, or use of electronic health information. Now, electronic health information, it's a little bit of a quirky term, I think, because the definition is essentially any electronic protected health information that would fit within the definition of a designated record set, but there's a little bit of an exception to that. For the first 2 years of the rule, are between May of this year, 2020, and May of 2022, you only have to exchange or allow access to or use of EHI that fits within the US CDI data elements, US CDI version 1 data elements. So I want to be clear, there's nothing in the rule that requires you to meet the US CDI standard at this point, but you do have to be able to exchange the data elements that are listed in that standard through May of 2022. And then after May of 2022, you have to be able to exchange, allow access to, or use of any EPHI that fits within the definition of the HIPAA designated record set. And we're going to talk a little bit more about both of those in a moment. So information blocking dates, the compliance date has already passed. You're listening to this on November 12th. So the compliance date, as we know it today, as I'm recording this, is November 2nd, as well as the enforcement date for the information blocking rule. And I think that's important to keep in mind, my comment as I sit here today, because there is a rule that's in front of the Office of Management and Budget, or OMB. We don't know exactly the text of the rule, but we do know the title of the rule. And based on the title of the rule that they're evaluating, it looks to be a rule that's probably going to extend some of the compliance and enforcement dates for one or both of these rules. So maybe by the time we get together on the 12th, I'll have more information for you and can update you in the live Q&A portion of the session. But as I sit today recording this, it is the compliance date of November 2nd. Again, you have to be ready to share the US CDI data elements by the compliance date. So, if you haven't already done that, that might be an issue for you. We'll, again, talk a little bit about exceptions in a moment with that. And then, as I already mentioned, May of 2022 is when you have to be ready to share any information that's in the designated record set. So, now, the enforcement activity for information blocking. The enforcement date for the information blocking rule is technically November 2nd, but both for the reasons that there's the rule in front of OMB, as well as just what has happened from the beginning of these rules, that is not exactly likely to happen. And I say that because the rule is different for how they're going to enforce against health IT developers and HIEs and HINs versus providers. So for health information developers, HIEs, and HINs, that enforcement activity will be done by OIG and will be subject to a civil monetary penalty. The civil monetary penalty rule for this was published in April of this year, but has not been finalized as I sit here recording this. So again, perhaps when we get into the live Q&A after you've listened to the recording, I may have an update for you on whether that rule's been finalized. But OIG has said they will not begin enforcement until the rule is finalized, and not likely until it's effective, which will be 60 days after it's published in the Federal Register. So the likelihood there's going to be any enforcement against those three types of actors in the near term is pretty unlikely. And again, we also have the rule that's with OMB that could push all of those dates out even further. And so one thing to think about is we don't know whether enforcement's going to occur for activity after November 2nd. And the only way that we can guarantee that enforcement won't go to any activity that occurs after November 2nd is if the compliance date for the rule gets pushed out. As I sit here today recording this, the compliance date, as I've mentioned several times, is November 2nd. So, you need to be watching those rules pretty closely because they could have a significant impact on whether you could be guilty of information blocking and have an enforcement action against you, even though the rule for the civil monetary penalties has not yet been finalized. So for providers, it's even more unclear. And I say that because for providers, they've said they will enforce the rule through disincentives. And again, as I sit recording this, there's been no rule promulgated for what the disincentives will be. So we won't know for sure what any type of enforcement action against providers is going to look like until that rule gets published. There's a time for comment to the proposed rule, and then of course the rule gets finalized and becomes effective. So I can't tell you anything about when that's going to occur. Obviously the federal agencies don't tend to give us a lot of leeway and a lot of feedback into when they're going to publish these types of rules. And with everybody focused on COVID, I don't know that it's likely we're going to see any time in the near term or anything in the near term. But again, that's something you have to keep an eye out for. And hopefully, as I've said a couple times, by the time we get together and we do the live Q&A as part of this session, I'll have an update for you on some of that. So keep your eye on what the regulators are doing, and if anything happens between recording this and our live discussion, then I'll update you. There also is a difference for the intent level that the government will need to prove as it relates to enforcement activity. And again, between the 4 different types of actors, there's a different intent requirement for health IT developers, HINs and HIEs, than there is for providers. So for health developers, HIEs, HINs, they can be guilty of information blocking if they know or should know their practice is likely to interfere with, prevent, or materially discourage access, exchange, or use of EHI. So that should have known or should know, as we have seen in other laws and regulations, is going to be important to consider. It's not only what you actually knew, but as you look at compliance with the regulations and what you should be doing, then should you have known that what was going on would likely interfere with, prevent, or materially discourage that access, exchange, or use. Now for providers, the intent criteria and what will find them guilty of information blocking is if they know their practice is unreasonable and is likely to interfere with, prevent, or materially discourage access, exchange, or use of EHI. So that's what you have to think through. Is it unreasonable for whatever you're doing? And is it likely to interfere? And so that is a little bit of a higher standard that the government's going to have to meet to find providers guilty of information blocking. So that's a little bit of good news for providers. But as I mentioned, there are several things you have to consider around that. And I'll get into that in more detail when I talk about things you should be doing. There are 8 exceptions to the information blocking rule. 5 of the exceptions really tie to instances where you don't have to share the data if you fit the exception. And 3 of the exceptions really tie to the way in which you share the data. So the 5 that tie to whether you have to share it at all are preventing harm, the privacy exception, the security exception, the infeasibility exception, and health IT performance. And these are pretty much what you might expect, but one of the things that everybody needs to be clear on, for the security exception, if you can demonstrate that, say, allowing a patient's application to connect to your system is going to create risk for your system or your data, then you could fit that into the exception. But if you evaluate the application and you look at it and say, well, this is really kind of a crappy application, it's not going to put our system at risk, but this is really not a great thing for the patient. You can educate them on that and inform them of that. But if the patient says, I don't care, I still want to connect, I still want to get my access by utilizing this app, then you have to let them connect. So being very clear on that. The risk of harm is kind of what it sounds like. And again, I'm not going to go into the details of the exceptions. I have put the link here to the ONC website where they've got a PDF document that goes through each of the exceptions in some detail. So that's for your reference. The three that talk about the way you fulfill the request are the content and manner exception, and the fees exception, and the licensing exception. Now, again, I'd encourage you to focus on some of those, because as we talk about some of the things you're going to need to think about and consider, you want to understand the exceptions pretty well, but there's just not enough time in this presentation to go through each of them in detail. So let's do a quick overview of the interoperability rule. And remember, I said at the beginning, I was going to focus on really the primary way this impacts providers. And so the interoperability rule has set some additional criteria for the Medicare conditions of participation. And so anybody that has to comply with those needs to think about this. So if you're out there as a physician practice, as a skilled nursing facility, as something like that, you can kind of, turn your ears off for a moment. But this is really predominantly going to be for hospitals. But if you need to meet Medicare conditions of participation, then these are things that are going to impact you. The interoperability rule also addresses the conditions of certification for health IT developers of certified health IT. As I've mentioned a couple times, I'm not going to focus on that piece of it. If that's what type of entity you are, obviously that's something you're going to need to look into in some significant detail. So the changes to the conditions of participation really fall around ADT, or admission, discharge, and transfer information. And it's going to require that you provide notification to certain other providers involved in the patient's care. This might be something you're doing currently. So if it is, then you're well down the path of getting this accomplished. But there also may be some additional factors that you need to consider, even if you do this today. So what ADT notifications have to be sent? You have to send notification of the patient's registration in the emergency department. You have to send notification of the patient's admission to your facility as an inpatient. So if the patient is, as a lot of times people use the term, quote, admitted to observation, that doesn't require a notification. It's only if they're admitted to inpatient status that requires the notification. You have to notify when the individual's transferred from your emergency department. You have to notify when the individual's transferred from any sort of inpatient service. So let's say a patient gets transferred from inpatient to rehab, or inpatient to skilled nursing, then that would require notification. You also have to notify when the individual's discharged from the emergency department or discharged from inpatient services. So, and this is one of the things to consider. There's nothing I read in the regulations that says that if I come into the emergency department, I'm seen and I'm discharged, that you don't have to send a notification for each of those activities. So, that's something to think about as far as making sure that you're sending all the notices you're obligated to send. I think, it'd be interesting to see how the clinicians that are receiving the notifications feel about it, because, if I get registered in the emergency department because I broke my arm, and maybe I'm in the emergency department for 6 hours or so for them to evaluate it, maybe set my arm, or give me a temporary cast or something else until I can go see my orthopod. Then that 4 hours later I'm discharged. I suspect for many physicians, their primary interest is knowing I was in the emergency department, but not so much knowing at the time that I'm registered, and then again at the time I'm discharged. I think for many physicians, it's likely going to be that their primary interest is just knowing I was in the emergency department. But this requirement says you have to notify of each of those items when I'm registered in the ED and discharged from the ED. Now, obviously, if I'm admitted as inpatient, there's a likelihood that I'm going to be there for a couple days. So my clinician might be interested in knowing I've been admitted as an inpatient to see if they want to come and see me or just keep track of what's happening with me. So the people you have to notify the patient's primary care physician if they've identified a primary care physician. You have to notify the patient's established primary care group or entity, or you have to notify any practitioner or other practice group identified by the patient as primarily responsible for their care. So when you think about this and consider this, who's primarily responsible for the patient's care? That may be a question you have to evaluate. If I'm coming in because I broke my arm, you probably don't have to notify my cardiologist, but what if I ask you to notify my cardiologist? Well, they're not going to be likely primarily responsible for my care for my broken arm. They're not really my primary care physician, but do you have to notify them if they're not, quote, primarily responsible for the patient's care? I don't have a good answer for you, and I think that could get a little complex with some patients. That might be the one-offs, but it's also something that you might want to consider. How would you handle it if you got that kind of request? You have to be able to share the patient's name, the treating practitioner's identification, and the name of the sending entity. So, who's the doc that cared for me in the emergency room or emergency department, your hospital, and of course, patient's name. Again, if you're sending any notification today, it's likely that you have that information already and you're processing it. But just make sure that you do include or always include those 3 data elements in addition to any information that might be relevant about why the patient's being seen. Again, for the relevant dates, you have a little bit of time, but not a lot actually. We're just over 6 months now, and not even that by the time you listen to this recording. The notifications as of today have to be sent starting May 1st of next year, 2021. And again, I'll just reiterate several times, you've already heard me say, there is a rule in front of OMB that based on the title, it leads us to believe that it's probably going to extend some of these compliance dates and/or enforcement dates. But as I record this, it hasn't been finalized yet. So again, I'm wait and see. I might have more news for you as we go into the live portion of this presentation at the end of the recording. So thinking about what do you need to do now? Well, I think there are a number of things that you need to do now. And as I talk through these, if you haven't done this already, one of the things you might consider is creating a task force. Because as we talk through this, you're going to see that it involves a number of departments, or likely will involve a number of departments within your enterprise. And so it's best, I think, to make sure you have all the players at the table, that everybody understands what the entity's obligations are. You may be looking at and saying, I'm the IT person, so here's what I need to be responsible for. But there might be instances where you have to make sure the data is there. You might be able to do something with the IT, but if you don't have the data within the system to actually perform the activity, then it's not going to be very meaningful. So That's why we're encouraging our clients to, if you haven't already, develop a task force around this and think through how you're going to handle it across everybody who might be involved. And as I said, as I go through each of these, I think it's going to, if it isn't already, be readily apparent that there are a multitude of business units within your health system that could very well be impacted here. So one of the things, and I think this is one of the more important things to consider, is determining what kind of actor you are under the information blocking rule. You're going to have a number of policies and procedures you need to review. You're probably going to have to review your contracts. You're going to want to look at system capabilities that you have today and what, if anything, might need to change about that. And then, of course, training and education considerations. So let's go through each of these. What type of actor is your organization? Well, likely you're a provider if you're on this call, but you might be a certified health IT developer. But I reiterate, and I can't emphasize this strongly enough, I always hear people talk about this in terms of patients and providers, but as a provider, you might fit the definition of another type of actor. So remember, the definition of a health IT developer of certified health IT is an entity that offers the certified health IT. So for example, if you have Epic and you offer Community Connect to your physician groups, then you are offering a certified health IT. So you now fit the definition of a health developer of certified health IT. That now subjects you to both the civil monetary penalties once they're finalized, and it also subjects you to the different intent standard from what a provider intent standard is. So I think these are things you want to definitely think about and consider. And also the way you do this, not only for your own organization, but for those organizations for which you've offered the EHR, your process might need to change, or you might need to consider and think about what you're going to give access to and what your responsibilities are versus the responsibilities of, say, that physician practice to whom you've extended that instance of Epic. Are you a health information exchange or health information network? Again, maybe because of something like Community Connect, you might fit that definition. Now, keep in mind the definition says it has to be more than 2 unaffiliated parties. So if everybody you offer Epic to is part of your enterprise, if you will, they're all affiliated, you might not fit that definition. And it also has to be for treatment, payment, and operation purposes. But again, you could potentially fit all 3 types of provider groups. You could be, all 3 types of actor groups. You could be a provider. You might be a developer because you're offering that EHR, and you could potentially be an HIE or HIN. So this is important to consider and think through what, if anything, you need to do differently based on the type of actor you are under which circumstances. You need to review policies and procedures and consider things like, how are you going to allow patient access to their records? Or, look at your policies and procedures for how you do it now, and what, if anything, might need to change to ensure you're compliant with this new regulation. Now, maybe nothing, perhaps, but I suspect that there probably is going to be something that needs to change in thinking through the requests coming in, and the fact that, under these provisions, if I bring in an app on my phone that says I want to use this app to be able to access my records, then that's important to make sure that's part of your policies and procedures, and people are aware that that is one way in which I can exercise my access right. And also keep in mind, I hear a lot of people talking about this and saying, well, what's the big deal? We already have patient access policies. We don't see any need to change that. Well, the other piece is it's not just patients, it's other third parties. You might be getting requests from other providers. You might be getting requests from public health entities. You might be getting requests from health plans. You might be getting requests from researchers. And so keep in mind that this isn't just applicable to patient requests for access. It is applicable to third-party requests for access. So for example, you may have a policy today that says if a researcher comes to us with a waiver of authorization that has been approved by a valid institutional review board or a valid privacy board, but it's not our institutional review board or our privacy board, that we're going to require them to submit something through our IRB or privacy board. And that's perfectly fine for you to have that in place today. However, under the information blocking rule, you're going to have to consider, is it unreasonable to require them to go through this? And is it going to interfere with or discourage the access, use, or exchange of the information? And so you may be obligated to share the data with that researcher, even though under your current policies or past policies, you wouldn't have. So when people look at this, I think it's a little broader in what you need to look at than what I think a lot of people are considering. So just think through, what kinds of requests you get today that you would just sort of off the cuff deny, and evaluate those against the rule to determine whether you can still do that. Now, obviously, if the researcher comes to you and they don't have a valid authorization, or if the document they share with you for the approval for their waiver of authorization, you learn that it's not from a valid IRB or privacy board, then those are going to be things that fit into exceptions and you can deny the request. But you need to be very cognizant of that and understand your current process. And for the interoperability rule, you might need to look at things like, what's your current registration process? How do you currently identify the primary care provider for patients? Do you have a solid process for that? I know when I was in-house in a healthcare organization, this was always a complex issue to try to make sure we captured the right primary care physician so that we could share information and have that continuity of care for the patient. And that's going to be even more important now to meet the ADT notifications. Now, if a patient says, I don't have a primary care physician, then that's not a problem. But it's every time they come in, are your registration staff asking for that information on a very consistent basis, so that the reason you don't have it is maybe because it doesn't exist versus you aren't asking and everybody's not following the same process. Potential new policies that you might need to consider, the process for addressing the exceptions to the information blocking rule. Who's going to have authority to assert that an exception exists and that it's going to be applied? Think through what documentation you will want to have to ensure that folks are recording why they believe an exception actually is met. Again, like with everything in compliance, the enforcement activity tends to come, weeks, months, years after the actual event occurred. And so you're going to want to make sure you have good documentation of why you believe that exception is applicable. And again, make sure that you have the applicable timeframes for making certain decisions. Some of the exceptions do have timeframes around them, so you want to make sure that you've documented those in the policy and people are aware of them. And what's your process for handling a request for access, exchange, or use on behalf of other parties? So those third-party requests that you might handle differently than you handle a patient request. So again, that may be something you feel like you've got in place today, but I would strongly encourage you to look at your policies and procedures. And you don't likely have a policy and procedure for the exceptions in place today, so consider that. What's the process for sending the ADT notifications required by the interoperability rule? That may be something you need a new policy and procedure around to make sure, again, that something exists that clarifies for your workforce what their obligations are. For example, the ED example I used a moment ago. you know, the rule requires that you do it sort of contemporaneous to the event occurring. Well, if I get registered in the ED at 11 a.m. and I get discharged from the ED at 2 p.m., could you possibly send both notices of the registration and the discharge? Um, I don't know. I think you probably can, but I think you want to make sure you evaluate and say if the registration and discharge from the ED is within this time frame, we'll just send them both at once. Or you might set it up that might be easier in your system just to send them as the event occurs, so nobody has to really, quote, worry about it at the time of discharge. But I think these are all things you want to consider and think about. Now, reviewing contracts, you may have contract terms that exist today that would constitute information blocking if you enforce those terms of the contract. Under the rule, those would essentially be considered invalid. In other words, they're not enforceable provisions of your agreement if they constitute information blocking. So you may want to look at existing contracts to say, okay, is there anything in here that we think would constitute information blocking, and make the other party aware that you don't believe those are any longer enforceable terms. You might need to review your existing business associate agreements to ensure that you don't have language in there that could constitute information blocking under the rule. So again, you don't have to put in place new agreements right away, but you do want to look at the terms and make sure that you don't have anything in the agreement that could constitute information blocking. And that if you do, you've made your business associate aware, or you've made the covered entity that you're the business associate for, that you're not going to follow that term any longer now that the rule's in effect. You're going to have to evaluate your system to make sure you have capabilities to do all of this. Does your system have the capability to send those required ADT notifications? Now remember, you have until May of next year, which is now just about 6 months away as you're listening to this. So you need to think through, you know, does our system have the capabilities today, and what's it going to take for us to add those capabilities so that we're ready to comply on the compliance date of May 1 of 2021. Does anything need to change? Maybe not. Maybe you've got a process set up already, but think through that and consider that. How does your how does your system store the information on the primary care provider? You know, is it all in the same location? Can it, you know, set up technology so it's going to grab it and it's going to always know where to grab from? How do you address when the patient requests that ADT notification be sent to an additional party? So maybe I do want it sent to my primary care, but if I came in for a cardiac condition, maybe I want it sent to my cardiologist also. And in thinking through, where is that going to get stored in the system? Because at least the last time I was looking at it and familiar with it, most EHRs have a place to store the primary care physician, but is it a standard place to store any additional providers? And let's say that you might have a record of who my cardiologist is today. Well, you don't have to send that necessarily to the cardiologist unless I request it, but if you set it up so that you're always going to send it to whomever is in that field, then you might be over notifying. And so, you know, it's something to think about and consider, where are you going to store that information so that if I do request another party get the information, you'll know where the data is so you can make sure the notification gets sent. Does the system have the capability to share the US CDI data elements? Now remember, it's not requiring that you comply with the US CDI standard, at least not today, but you have to be prepared to share the data elements. And if you're not prepared to share the data elements, then you're probably going to want to have a process in place that you evaluate it against the information blocking exceptions to see if you can fit that within an exception. And you might be able to document, if you choose and believe you can fit an exception, you just document that we're always applying this exception, or we're always applying it until our system is capable of sending this. Now, again, I always remind folks, keep in mind that you only have to give access to or exchange or use the US CDI data elements, but that goes away in May of 2022. As of May of 2022, you have to be able to share any data that's in the designated record set. So keep that in mind. You also are going to need to educate your workforce. Obviously, you're going to need to educate them on what the rules are and what they mean to them. You're going to have to tell them what they're going to need to do that's new or different from what they've been used to doing within your organization. You're going to have to educate them on any updated or new policies and procedures that are going to impact them and how they handle information. You're going to have to tell them what they're going to do differently or new when it comes to requests from third parties, not just the patient. And again, you might want to refresh them on what the designated record set actually is. A lot of people really focus in on the medical record or the electronic health record. Well, the designated record set is much broader than that. And I was just listening to a webinar on charity care, and they were talking about keeping the documentation that you utilize to determine that the patient is eligible and meets your charity care policy. And I thought about that in relation to this rule because that data is used to make a decision about the patient. So I might give you a copy of my income tax statement. I might give you a copy of pay stubs. I might give you a copy of a number of documents. You're probably not going to consider them part of the medical record. Maybe you do, but most organizations, I don't think, do put them into the medical record. But that is definitely documentation used to make a decision about me. And that would fit within the definition of designated record set. So when you think about where data is, you have to make sure you think about where all of your data is and not just the electronic medical record. Remember, designated record set is the electronic medical record, financial information, and any other information used to make a decision about the patient. So again, that may be something you need to really focus in on and re-educate your workforce on. Again, that's a little bit of time for that one because that doesn't start until May of 2022, but it's definitely something you want to think about. So a few activities that you got a little time to think about, and part of this ties back to what I was just talking about, determining where all your EPHI resides for patients and just really doing a strong data inventory and making sure you're very clear on that, because again, that access request starting in May of 2022 has to be for the data in the designated record set. Think about updating your contracts to eliminate any terms that could be information blocking. So again, if you have a contract that expires in June of next year, you want to have evaluated it for any terms that might be information blocking. And then as you update it next year, then you obviously want to eliminate those terms that could constitute information blocking. Think about things you might want to audit and monitor going forward. For example, any requests for access, exchange, or use of EHI once the rule is out there and you've got processes in place and the compliance dates have passed for the particular rule. Monitoring, after the rule goes into effect next year for ADT notifications, then monitoring and auditing to make sure that those notifications are actually going out. So with that, we are now ready for the live Q&A session for this presentation. I thank you for your time and attention and appreciate your interest in the topic and listening to me. I hope you found it useful.